I want to give a little bit of background on why residents or physicians or patients will be excited about these types of interventions. And that's because, the current orthopedic model doesn't work for every patient, right? So, my first go-to, if somebody has some new pain, right, is physical therapy, right? Like everybody in this room, we all believe very strongly in physical therapy. But if that doesn't help, then the typical algorithm is cortisone. It's surgeries like meniscectomies, and then joint replacements if things don't get better after a while, right? So let's talk a little bit about some of these interventions. We all probably are familiar with the systemic side effects of cortisone, like hyperglycemia, osteoporosis, immune suppression, etc. My biggest problem with it, though, from my perspective, is that it's toxic to cartilage. This was the earliest article I could find on that. We've known this in some fashion or another since 1975. More recently published in JAMA was an article where every 4 months, patients were injected in their knee joint with triamcinolone. The other group was injected with saline. After 2 years, there was no significant difference in pain between the two groups, but the group that got injected with triamcinolone and no local anesthetic had significantly less cartilage. So long-term, not such a great option for a lot of people. This is a study published last year coming out of the UK. It took a look at patients with knee osteoarthritis receiving cortisone injections and how likely they were to progress towards a knee replacement. Each of these patients were controlled with, how severe their osteoarthritis was, their age, their BMI, their activity level, 18 different subgroups to control for cortisone injections, and it's about 6 times as likely that you're going to progress to a knee replacement if you're getting cortisone injections versus not. In fact, each injection increases your risk of a knee replacement about 10%. 99.9% of the injections into tendons in this country are cortisone. I'm not a pathologist, but even I can tell that the image on the right is not a healthy tendon. The middle is saline, the left is normal tendon. These are in black and white because they were first published in 1973 in Journal of Sports Medicine. This is stuff we've known for a long period of time. And then, of course, various orthopedic procedures we know lead to further degradation of the joint and osteoarthritis. The first description of what happens when you remove a meniscus, this is a total meniscectomy, was from Dr. Fick in 1904 that described a knee cavity forming afterwards, leading to severe osteoarthritis. Over the last 10 to 15 years, there's been a lot of new studies that have come out that have taken a look at meniscectomies versus sham surgeries versus physical therapy, and most of them have concluded not a good strategy, or at least no better than placebo, no better than physical therapy doing these types of procedures, but it does lead to increased osteoarthritis changes. So this was my favorite one of them, which was a sham surgery published in the New England Journal of Medicine. So they actually put patients to sleep, poked holes in their knees, told them they had a meniscectomy, sent them to therapy, found that those patients did not do any better than people who actually had the surgery. And then, of course, sometimes joint replacements are a good idea, especially for those most debilitated by continued pain, but they're, of course, not without their drawbacks. I think when I was here, I took care of 2 patients with above-the-knee amputations from persistent infections in knee arthroplasties. This is data from published a month ago in the British Medical Journal that took a look at the level 1 evidence for 10 of the most commonly performed orthopedic surgeries. It found that one of the surgeries, carpal tunnel release, had good evidence, whereas the rest of these, which even includes things like ACL reconstructions, rotator cuff repair, et cetera, stuff we see all the time, had no to weak evidence versus either conservative care or sham surgery. So that's kind of the background, set the stage as to why you might have a patient, especially one failed conservative care, failed cortisone, doesn't want more invasive surgery, et cetera, who's excited about something like orthobiologics. In the last 10 years or so, there's been a number of major academic centers that have set up their own regenerative medicine departments, most notably some of the ones on this list. And the number of publications really in the last 5 years or so for bone marrow concentrate and in the last 15 years for PRP has gone up substantially.